Today I am going to teach you something about direct and indirect ophthalmoscopy. Direct ophthalmoscopy can be easily learned under the following headings. First is the definition of the equipment. Next is optics of direct ophthalmoscope. Then you should know the method of examination of a patient by using direct ophthalmoscope. And while examining the patient, you should know what are the parts that can be examined and should be examined by the direct ophthalmoscope. Then you should know the parts of the direct ophthalmoscope and the apertures that are present in the direct ophthalmoscope and their uses. Finally, we can summarize the salient features of direct ophthalmoscopy. The last point that we have to remember is the maintenance of the direct ophthalmoscope, which is very much essential so as to expect a good durability of the equipment. Definition. The definition of direct ophthalmoscopy is should be read like this. Direct ophthalmoscopy can be defined as a procedure of examining the posterior segment of the eye by using an equipment by the name direct ophthalmoscope. In fact, it also helps in identifying media opacities in both anterior and posterior segment. So it's not an exclusively posterior segment examination equipment. Anterior segment details also to some extent are obtained by using this particular ophthalmoscope. The ophthalmoscope was invented by von Helmholtz in 1850. This picture gives the optics of direct ophthalmoscope. In this picture, you can make out that there is a source of light in the form of bulb. There is source of light in the form of bulb, and this source of light is converted into parallel beams by using two lenses, lens 1 and lens 2. And this light is bent at 45 degrees to enter the patient's eye by using a prism or a 45-degree inclined mirror. Then the examiner has got a small hole near this 45-degree bent mirror or a prism through which he can see the inner part of the patient's eye, that is the posterior segment of the patient's eye. Around 15 degrees of the posterior segment will be eliminated at a given time, and the 15 degrees of the posterior segment can be easily seen by the examiner. These compensation lenses are nothing but the lenses which have to be used according to the refractive error that is present in the patient. If the patient is having minus power, you have to turn this lens wheel into minus powers. And if the patient is having hypermetropia, you have to turn the lens wheel into plus powers. There is an aperture wheel wherein you can adjust the apertures, and the details of the apertures and the filters will be told in the next few slides. This is an extension of the optics of direct ophthalmoscope. You can see in this particular picture that an observer can peep into the fundus without the aid of any lenses if the patient is emmetropic and the observer is also emmetropic. In the second case, the observer is emmetropic and the patient is hypermetropic. So we need the help of plus lenses which can be adjusted in the lens dial that is present in the direct ophthalmoscope to examine the patient properly and to visualize the structures of the posterior segment properly. In myopic patients, obviously we need minus lenses or concave lenses so as to focus the posterior segment of the patient. In some cases, both the observer and the patients may be having refractive error. In such cases, the sum total of the observer's and the patient's refractive power should be adjusted so that the observer can easily visualize the posterior segment structures. The examination with direct ophthalmoscope can be classified under two headings. One is distant direct ophthalmoscopy and the other one is near direct ophthalmoscopy. Distant direct ophthalmoscopy is done at a distance of 1 meter from the patient's eye, that is an arm's distance, and this examination in a normal case shows uniform bright frontal glow in the normal people. But if there are any opacities in the media, either in the anterior or posterior segment, like corneal ulcer, corneal opacity, uh, cataractous changes in the crystalline lens, or some opacities in the vitreous cavity, it is seen as dark shadow or shadows in front of the bright frontal glow. Near a direct ophthalmoscopy is done by going very close to the patient, and basically we visualize the parts of the fundus by peeping through the patient's pupillary area. Here you have to go extremely close to the patient so that you can see the structures in the posterior segment, namely the disc, vessels, background retina, macula, and also the periphery of the retina. This is a picture of distant direct ophthalmoscopy. You can observe that the examiner is holding the ophthalmoscope in the right hand, and he is using his right eye to examine the right eye of the patient. So it's all right, right, right for the right eye, left, left, left for the left eye. So at an arm's distance he is examining. Basically he is searching for the fundal glow. If fundal glow is very bright and uniform, then it is a normal case. If there are any opacities seen, then obviously there are some opacities in the media, either in the anterior segment or in the posterior segment. This is the picture of near direct ophthalmoscopy. You have to go as close to the patient as possible and peep through the pupillary area to visualize the posterior segment structures properly. Next, you should know the parts of ophthalmoscope. This is on the left hand side is from the patient side how you see the ophthalmoscope. On the right hand side from the doctor's side how you see the ophthalmoscope. This is the picture of the ophthalmoscope, which shows various parts of the ophthalmoscope. Any ophthalmic equipment for that matter will be having three parts. One is illumination part, another one is optical part, the third one is a mechanical part. So here you can observe that doctor's eye window is the optical part, and the place where the bulb is kept is the illumination part, and the handle can be considered as a mechanical part which helps us in maneuvering the equipment to various positions so that we can see all the quadrants of the retina. So from the patient side you have a detachable head which can be fixed to the handle. You have a mirror. You have what is known as lens selection wheel, which is nothing but set of plus lenses and minus lenses which are used so as to focus the posterior segment of the patient who is having a refractive error. For example, if he is having -5 diopters of refractive error, you have to turn this wheel to -5 and then observe the posterior segment of the patient. If the patient is having hypermetropia, then you have to turn the lens towards plus lenses and then examine the posterior segment. Now I'll describe the procedure of direct ophthalmoscopy. First thing is to position the patient, of course, in an erect position, in a sitting posture. Position the patient so that the ophthalmoscope is held directly at the level of the patient's eye, and turn on the ophthalmoscope with the lights set to the correct aperture. Correct aperture, the apertures I'll describe on a later slide. It is essential to darken the room for the examination to enable clearer visualization of the retina. If the room is very dark, you can easily visualize the posterior segment much clearly than when the room is very bright. Ask the patient to fixate on a target behind you for the duration of the examination. We normally ask the patient to look straight ahead. Especially if we are in a vision testing room, we ask the patient to look at the Sneller's chart straight away so that we can see because of this stability and fixation, we are able to assess the fundus much more clearer than when he keeps moving the eyes. Now you direct the ophthalmoscope 15 degrees from the center and look for the red reflex at a distance of approximately 1 arm's length from the eye, that is around 1 meter distance from the patient's eye. Next step is to do near direct ophthalmoscopy. For this, you have to simply follow the red reflex until you see the retina. If you lose the red reflex in between, come back until you find it again and repeat the procedure, and you will definitely succeed in seeing various parts of the fundus in near direct ophthalmoscopy. When patient looks straight ahead, you will be able to view optic disc very clearly, and if the patient looks at the direct ophthalmoscopy light, then macula comes into view, and then you will be able to assess the foveal reflex and the macular details when the patient looks at the ophthalmoscopy light. A right eye of the patient should be examined by the right eye of the examiner, and examiner should hold the ophthalmoscope in the right hand. So obviously this will tell you that for the left eye, it is left hand and left eye of the examiner for examining the left eye of the patient. The examiner normally uses one eye for examining the patient's eye. As you know very well, direct ophthalmoscopy is uniocular. So it is advisable to open the other eye rather than closing it. Some people develop the habit of closing the other eye. That should not be done. And examiner should also learn to suppress the image seen in the other eye. He should concentrate on the details of the image that is seen by the respective eye through which he is seeing the fundus of the patient. Then you have to examine the structures methodically as follows. First, you have to examine the optic disc, its shape and cupping of the disc and the details of the disc. Then you have to go to the macula. Then you have to assess the vessels of the retina, both arteries and veins. Background retina is normally pinkish red due to the choroidal reflex that is given. So if there are any hyper pigmentations and hypopigmentations, you should be able to identify this. If the background retina is pinkish red, then it is normal. Then you have to concentrate on examining the periphery of the fundus by asking the patient to look at various directions conveniently so that you can see the superior peripheral part of the superior aspect, inferior aspect, medial aspect and the lateral aspect of the retina. All four quadrants of the retina, that is superotemporal, superonasal, inferotemporal and inferonasal part should be examined with proper care so as to write the details of all these four quadrants. If there are any abnormalities, you should be able to identify and then write down in these four quadrants. This is a diagrammatic picture which will show you how you are going to see the posterior segment of the eye when you use direct ophthalmoscope. You must remember that you are going to see a virtual erect image behind the patient's fundus. The enlargement of the image is around 15 times, and these are the structures that you are going to examine. Firstly, the optic disc, and you examine the optic cup. Then you have to examine the macula, which is around 2 disc diameters away from the temporal edge of the optic disc, and there is some bright spot by name fovea centralis in the middle of the macula, which keeps shining as you focus the light on that. That has to be examined, and the artery should be examined, veins should be examined, then the background retina. This is the normal fundus. This is the picture of the normal fundus. Based on this, you should be able to identify any exudates, hemorrhages or any kind of changes which are present in the posterior segment of the eye. These are the apertures that are present in the direct ophthalmoscope. The large aperture is for dilated pupil, while the small aperture is for the undilated pupil. Half light is used when part of the corneal reflex is obstructing the view. If you use half light, then you can avoid that reflex and you can see the details of the fundus. Now then you have a red free light, then you have a slit, you have a blue light, cobalt blue light, and a grid. In the next slide I am going to explain what are the uses of these particular apertures that are present in the direct ophthalmoscope and how we can make use of these apertures to identify various diseases. Large aperture, as I told you earlier, is basically to examine the dilated pupil cases. Small aperture is to see the fundus in undilated pupils. Half circle is to avoid the reflexes in other part of the cornea, so that you can easily discern the details of the posterior segment. Slit is to find out either the elevation or the depression in any lesion which you find in the posterior segment. Grid will help us to measure approximate distance between the lesions and also helps in calculating cup disc ratio of the optic disc. Cobalt blue light is helpful in identifying, of course, along with the fluorescein dye, various retinal and corneal lesions. So here you can visualize that even though it is an exclusively posterior segment examination equipment, sometimes corneal lesions are also can be examined by the cobalt blue light of the direct ophthalmoscope. So in some cases it also helps us in assessing the anterior segment. So basically you must remember from the earlier slides that I told you that it will help in identifying the media opacities of the anterior segment, and here in this point we are coming to know that the corneal lesions can also be assessed with the fluorescent dye by using cobalt blue light of direct ophthalmoscope. So these are the 2 points that have to be mentioned in case you are asked what are the occasions wherein it can be used for the examination of the anterior segment also. So red free light helps us to obtain the details of veins, arteries and nerve fibers. In glaucoma, it will help us to identify the nerves that are damaged by the glaucoma. These nerves will be much lighter than the normal nerves which are not affected by the glaucoma. This is the help of red free light. Now that ophthalmoscope, as you know very well, is an indispensable equipment. So how to take care of direct ophthalmoscope? You must be able to have a clear and full knowledge of taking care of the direct ophthalmoscope, because it's your responsibility to see to it that it is kept durable rather than getting spoiled much earlier. The battery should be fully discharged and recharged once in every few months to maximize the battery life. After fully charging the battery, the bulb should first be switched on at sub-maximal illumination, because suddenly if you raise the illumination it may burn and the cost of the bulb is very high. So it has to be maximal illumination for 1-2 cases, at sub-maximal illumination for first 2 or 3 cases before employing full illumination to maximize the bulb life. So lenses are stuck to the dial. The plus lenses and minus lenses are stuck to the dial by using a glue which is soluble in acetone and related solvents. So therefore never use these solutions to clean the ophthalmoscope. So what should be used? The ophthalmoscope may be cleaned using mild alcohol or detergent and a soft cloth. A cotton bud should be used to clean the viewing window and aperture window in a circular sweeping manner. Ophthalmoscopes come with twist and fit as well as automatic lock heads. Ascertain the head connector in the scope and fix head accordingly. Sometimes if you are not very good at fixing this particular head, the equipment may get spoiled and it may have to be repaired. Always store the ophthalmoscope in its case when it is not in use, otherwise it will accumulate dust and it will be useless. If it will be used for a long time, the battery, remove the battery. If it's not going to be used for a long time, that is if it will be unused for a long time, remove the battery and store the ophthalmoscope. Dispose the batteries appropriately. Keep the instruments in its case or pouch when not in use. Make sure that the on-off switch is fully turned off. A click sound will be heard when you turn off before placing the equipment in its case. Discharge the batteries by placing the ophthalmoscope handle in the charging base at the end of each working day. When the ophthalmoscope is not likely to be used for long periods of time, as I told you earlier, remove the batteries from the handle to avoid leakage. Wipe dust off the outside of the instrument daily. While storing the instrument, keep the lens disc on the 0 setting. As you know, it starts from 0 and then goes towards +1. The anti-clockwise, it goes towards -1 depending upon which equipment you are using. So you bring the lens disc to the 0 setting so dust does not build up on the other lenses. Other lenses will be lenses, but this 0 will be an empty hole, just a hole with no lens. So dust cannot accumulate here. Some ophthalmoscopes include a shutter for the viewing window. It should be closed when the instrument is not in use to prevent dust from entering this particular equipment. This is how you take care of direct ophthalmoscope. So now, after knowing everything about direct ophthalmoscope, we will try to summarize the salient features of direct ophthalmoscope. Firstly, you must remember that it is an uniocular equipment. Uniocular, only one eye is used to examine the patient's eye. It is easy to operate and use this particular equipment because it's very easy to learn the maneuver of examining the patient by using this equipment. So it is very popular and very widely used equipment in various eye clinics. Retina can be examined even if pupil is not fully dilated. That is the advantage of direct ophthalmoscope. It is an independent equipment and no accessories are required. Like in other equipments, you need lot of accessories. Here, no accessories are required. Only the equipment is enough to examine various details of the posterior segment. So one of the best equipments to examine the posterior pole of the fundus. When I say posterior pole of the fundus, it includes optic disc, macula, arterial arcade, superior temporal and inferior temporal arterial arcades, and the area close to this optic disc and the macula. The magnification being 15 times, it is easy for you to ascertain various abnormalities that could be present in an abnormal case. For example, in diabetic retinopathy, if there are exudates and hemorrhages, even very small microaneurysms can be easily visualized because of this 15 times magnification. Virtual erect image is seen behind the patient's fundus. This is another salient feature of this particular equipment. So very easy to interpret as virtual erect image is present. It's not an inverted image. But unfortunately, the negative points are no stereopsis or depth perception will be present when you are using direct ophthalmoscope. So next disadvantage is that light source is not very bright enough to see the posterior segment in presence of some opacities like cataract and vitreous hemorrhage. Another disadvantage is that far periphery of the fundus cannot be visualized properly with the direct ophthalmoscope, so you are likely to miss various peripheral retinal degenerations and peripheral retinal holes if you entirely depend upon this particular equipment to do the diagnosis of the posterior segment. After knowing everything about direct ophthalmoscope, we will now come to indirect ophthalmoscope. Indirect ophthalmoscope equipment is slightly complicated when compared to direct ophthalmoscope. It has got a headband, it has got condensing lenses. So just like in any other ophthalmic equipment, it has got a mechanical part, it has got an illumination part, and it has got an optical part. The mechanical part is this headband. The illumination part is the light that is present inside the indirect ophthalmoscope. And the optical part, you will have one eyepiece for the right eye and one eyepiece for the left eye, which have to be adjusted according to your interpupillary distance. So as I told you earlier, just like any other ophthalmic equipments, it has got three parts: an optical part, and an illumination part, and a mechanical part. This can explain the optics of the indirect ophthalmoscope. You can see that by using indirect ophthalmoscope, and along with that we use condensing lenses. So by using condensing lens of plus 20D lens, 20 diopters of lens, you can observe that the patient eye is examined by the examiner, and an aerial image is formed in between the condensing lens and the observer's eye. And this image that is formed is real and inverted, in contrary to the virtual and direct image which you normally see in direct ophthalmoscope. So in indirect ophthalmoscope, what you are seeing is an aerial, real inverted image in between the condensing lens and the examiner. That you have to remember. This is the optics of indirect ophthalmoscope. You can see that the rays that are coming from the patient's eye are going through the condensing lenses, which is held at an arm's distance from the examiner, and these rays are going to get reflected by using a prism or a mirror which are inclined at 45 degrees, and these rays are sent uniformly to both the right eye and the left eye. And you see that the interpupillary distance is converted into a smaller distance by this equipment, and stereopsis can be achieved because of the binocularity of examination in this particular equipment. And what you see is a real inverted image in between the condensing lens and the examiner. These are the parts of the indirect ophthalmoscope which you have to know. First, you have headband height adjustment knob, which will help you to adjust the knob in such a way that the height of the headband can be adjusted. Next, you have a battery. Some equipments may not be having battery. It may be direct connection to the AC power, but here we have a battery backup which will last for about a few hours. Headband size adjustment knob is also there. Then headband tension can be adjusted by using these two knobs which are present on either side. Then you have a bulb inside, and there is an angle knob. Filter lever is to change the color of the light. Then you have a mirror angle control. You have a front window, and then is an aperture selection lever depending upon which aperture. For example, if the pupil is not very well dilated, then a small aperture. If the pupil is well dilated, then you have a larger aperture. Just like you have cobalt blue filter and you have a red free light which are present in direct ophthalmoscope. The same way you have all those color lights here. Brightness control knob is there, and there is a teaching mirror which is not shown in this particular picture. The purpose of the teaching mirror is to teach the student, like whatever the examiner is seeing, that can be seen at 90 degrees by the student, and examiner can teach his student whatever he is seeing. He can describe and then teach the student by using this teaching mirror. This teaching mirror is not there in this particular labeling, because it will be hidden behind this aperture selection lever. Now we will go to the procedure as to how we should do binocular indirect ophthalmoscopy. First, you have to adjust the ophthalmoscope, keep the headband and adjust in such a way that the headband fits properly and very firmly on your head. Next you have to adjust the interpupillary distance. You have an eyepiece for the right eye and an eyepiece for the left eye, which are movable. Once you move and keep in one position, they are steady in that particular position. So you bring it to your convenient interpupillary distance. Check the illumination intensity. Usually start with lower illumination. That is the rule for any ophthalmic equipment. Never ever start at a higher illumination, or you should not switch off the equipment when the equipment is in higher illumination, and next time when you switch on, suddenly the bulb may burn, and most of the bulbs are extremely costly, and hence usually start with lower illumination and slowly increase the illumination as needed and as tolerated by the patient. So your next step is to examine your thumb of the stretched arm. You stretch your arm and examine the thumb, and close your left eye, and with the right eye if you see the center of the thumb, and then you do the same procedure by closing the right eye and then you examine the thumb. If the thumb is seen in the central part in both the right eye and the left eye eyepieces, then it means that the adjustment is proper. Then you can proceed to examine the posterior segment of the patient. Apply the filter if desired. Patient should be in a supine position, and you should normally go to the head end of the patient and examine the patient. Patient should be looking directly up initially, that is primary position, and after that, depending upon which periphery of the fundus you want to see, you can ask the patient to turn to various directions. Basically, to examine the posterior pole of the eye and the posterior segment, the central part of the posterior segment, you have to ask the patient to look straight ahead. That is, he has to assume the primary position. So examiner should initially stand to the side of the patient, leaning over the patient. Keep handheld lens approximately 2 inches away. I am talking about plus 20D lens. There are various types of condensing lenses that can be used, but very commonly used lens is around plus 20 diopters. That has to be kept around 2 inches away from the patient's eye. Moving it closer or further away from the eye to focus and refine the view, you have to have a lot of skill in focusing the posterior segment by using this condensing lens and the binocular indirect ophthalmoscope. Examiner then swivels his view around to view different parts of the retina by tilting the head and walking around the patient. The doctor instructs the patient to look at various extremes of their vision so as to visualize the posterior segment properly. The macula normally is examined at the last as the light is bright, and patient's cooperation for BIO may reduce drastically if macula is examined at the initial stages of binocular indirect ophthalmoscopy. Additional aspects that I have to mention while examining the posterior segment of the eye is that full dilatation with tropicamide and phenylephrine hydrochloride is mandatory to examine the fundus with binocular indirect ophthalmoscope. Otherwise, the details that are going to be discerned will be extremely minimal and useless. Next, one more technique which will help the examiner to find out various diseases in the periphery is the scleral depression. A technique which is commonly used with binocular indirect ophthalmoscopy is scleral depression. This complements the dynamic view of the retina and vitreous. The forward and inward curvature of the globe in the anterior portion of the eye obscures and prevents the peripheral viewing. Therefore, scleral depression is needed to indent the sclera and bring the peripheral retina into view. To depress the sclera, a scleral depressor is placed against the sclera and gentle firm pressure is applied. This pushes the sclera and the retina into the examiner's field of view during the binocular indirect ophthalmoscopy examination. Thimble scleral depressor is the commonest of all, even though you have plenty of um, various kinds of scleral depressors. The commonest one is the thimble depressor. So these are the various scleral depressors that can be used. So you can observe that thimble depressors which are there on your right hand side are the commonest ones that are used by the ophthalmologists. This is how you are going to wear the thimble depressor before depressing the peripheral part of the retina so as to see the anterior most part of the retina, especially when you want to see the ora serrata and of course very close to pars plicata and plana. Then you can use these two this particular thimble scleral depressor. This is the technique of scleral depression. Patient looks down, depressor on margin of the superior tarsal plate, or some people put it on the globe only by anesthetizing the globe. Depressor advanced into the orbit as patient looks up, but no depression applied as yet. Scleral depression is applied gently to area of interest so that the area of interest comes into the center and you will be able to see through the pupillary area. This is the optics of seeing the peripheral part of the retina or the anterior most part of the retina with the binocular indirect ophthalmoscope and the condensing lens. You can bring that particular part into the view by pushing it towards the pupillary area. This is how you are going to do binocular indirect ophthalmoscopy. This is another model which is known as spectacle model of indirect ophthalmoscope. You must know that there are two models. One is headband model, another one is spectacle model. Here I am showing you the spectacle model. She is holding 20D lens at a distance of around 2 inches from the patient and trying to visualize the image. And it takes a lot of time for you to get the image, and this particular procedure is slightly difficult when compared to direct ophthalmoscope, and you need lot of practice to visualize the inverted real image of the retina that is going to be formed in between the condensing lens and the examiner's eye. This is the headband model which I have already shown you, and I have already told you the parts also. And one part which was missing in that particular diagram was a teaching mirror. You must know that teaching mirror is extremely useful in learning, especially when a retinal detachment case is being assessed, which is difficult to assess by a junior doctor. A senior doctor can easily teach him through the teaching mirror which is present in the indirect ophthalmoscope. Finally, you should know how to do fundus drawing. Fundus drawing is done by writing 3 circles and various radial lines. The first circle represents the equator, and the second circle represents the ora serrata, and the third circle represents junction of pars plicata and pars plana. So while doing the fundus drawing, as I told you, whenever you are examining a patient, you are examining the patient from the asking the patient to lie down on the supine position, and then you are going towards the head end of the patient, and from there you are going to examine the fundus. Once you examine the fundus, what image you are seeing is an inverted uh, real image, inverted image. It is both vertically and horizontally inverted image, and that has to be written on the chart. Chart should be kept like this: 12 o'clock towards the leg end of the patient, 6 o'clock towards the head end of the patient, 9 o'clock and 3 o'clock accordingly. And whatever you are seeing, you have to go on writing in that particular chart, and it will become a proper fundus drawing. Now we will go and learn something about how to take care of the indirect ophthalmoscope. Just like how you take care of the direct ophthalmoscope, our aim is to keep it very clean and see to it that the illumination part is not not spoiled, and then the longevity or the durability of the equipment comes for a very long time. Keep the instrument in its case when not in use. That is the regular rule. Make sure that on and off switch is fully turned off. A click sound will be heard before placing the instrument in its case. Recharge the batteries at the end of each working day. Wipe the headband and the instrument surfaces with a cloth dampened in mild disinfectant every day, because so many people would have used it. Or even if one person uses it, we have to disinfect it by cleaning the surface with a cloth dampened in mild disinfectant. Clean the lens by using hard contact lens cleaner and warm water, and then drying it with a soft lint-free cloth. Sometimes we may have to sterilize, especially for operation, we may have to sterilize the condensing lenses in a Sidex solution for about 5 to 10 minutes, or by ethylene oxide sterilization, or by placing it in a formalin chamber. You can also autoclave the lens in a steel chamber with perforation for steam. These are the various methods by which you can clean the condensing lens, which is used in indirect ophthalmoscopy. After knowing both about the direct and the indirect ophthalmoscopy, it is very important, right from the examination point of view and from the Viva OC point of view, that you should know almost all the differences between direct and indirect ophthalmoscopy. There are around 15 differences between direct and indirect ophthalmoscopy, and it is better you know all the differences very well and the importance of these differences very well. In direct ophthalmoscope, you must remember that it is uniocular, while indirect ophthalmoscope is binocular. There is a virtual erect image formed behind the patient's fundus in case of direct ophthalmoscope, while what you see is an inverted real image that is formed in between the condensing lens and the examiner's eye in case of indirect ophthalmoscope. Magnification is 15 times in case of direct ophthalmoscope, while the magnification depends upon the condensing lenses which are used in indirect ophthalmoscope. The normally used condensing lenses are 13 diopters lenses, 20 diopter lenses, and 30 diopters lenses. 60 by 13 means whatever value you get, roughly around 5 times is the magnification when you use 13 diopters of condensing lens. 60 diopter is nothing but the dioptric power of the eye. When you want to calculate the magnification in indirect ophthalmoscope, you have to divide the dioptric power of the eye by the condensing lens which you are using to examine that particular patient. Normally used condensing lenses by almost all the ophthalmologists is 20 diopters, but some doctors may also use 13 diopters and 30 diopters of condensing lenses also. So if it is 13 diopters condensing lens that is used, then the magnification will be 60 divided by 13, approximately 5 times. So the commonly used condensing lens is 20 diopter lens. 60 divided by 20 will be 3 times the magnification. Then if 30D lens is used, 60 divided by 30, that is 2 times is the magnification. In direct ophthalmoscope, the illumination is not very bright, but the illumination is extremely bright in case of indirect ophthalmoscope. No stereopsis and depth perception. If you read about binocular single vision, you will understand the importance of stereopsis and depth perception, which are very important, especially in diagnosing retinal detachment cases. So this stereopsis and depth perception is not present in direct ophthalmoscope, while good stereopsis and depth perception is present in indirect ophthalmoscope, and it is extremely useful in diagnosis of retinal detachment cases. And assessment of retinal detachment cases is extremely easier if there is a good stereopsis and depth perception. Field of view is much smaller in direct ophthalmoscope. As you know very well, the magnification is very high. When the magnification is very high, obviously the field of view will be much smaller, while the field of view will be relatively larger in all types of condensing lenses when you use indirect ophthalmoscope. In direct ophthalmoscope, only posterior pole can be very well seen, but in an indirect ophthalmoscope, far periphery even up to ora serrata is well seen, and it is very useful in identifying retinal detachment cases, especially the holes that are responsible for causing retinal detachment can be easily identified by this phenomena of the indirect ophthalmoscope, especially with scleral depression. Illumination being extremely less, the fundus cannot be seen in cataract cases in direct ophthalmoscope, while bright illumination which is present in indirect ophthalmoscope helps in visualizing the fundus even if there are cataract exchanges and vitreous hemorrhage. Even in such cases, you can peep into the fundus because the light is extremely bright, and the real inverted image that is formed is relatively clear so as to make out some changes in the posterior segment. As you know very well, in direct ophthalmoscope, no condensing lenses are used, but in indirect ophthalmoscope, condensing lenses of 13 diopters, 20 diopters or 30 diopters can be used, and very commonly used condensing lens, as I keep telling you throughout this lecture, is 20 diopter lens. Dilatation is not mandatory in direct ophthalmoscope because even without dilatation of the pupils, you will be able to easily visualize the posterior segment in direct ophthalmoscope, but dilatation is mandatory in case of indirect ophthalmoscope, and the detailed assessment is possible only if you dilate the pupil with tropicamide and phenylephrine hydrochloride. There is no teaching mirror in direct ophthalmoscope. In indirect ophthalmoscope, there is a teaching mirror which will help us to teach the students and the beginners, and it is very useful in teaching various aspects of retinal detachment, especially for which we need lot of stereopsis and depth perception which are present in BIO, binocular indirect ophthalmoscope, and it is very easy to teach the junior doctors by this particular teaching mirror. Direct ophthalmoscopy is normally done in sitting posture, erect posture, while binocular indirect ophthalmoscopy is done with patient in the supine position. One more difference is that in direct ophthalmoscope you have two kinds of examination, that is near distant direct ophthalmoscopy at a distance of 1 meter, and near direct ophthalmoscopy which is very close to the eye of the patient. But in indirect ophthalmoscope you have only one kind of examination, that is examination at 1 meter distance. So another difference is that some examiners feel that it is not good to examine children with direct, as we go very close to the patient and the patient may get scared, and they feel that indirect ophthalmoscope is much better to examine the children as we examine the patient at 1 meter distance. Final difference between the direct ophthalmoscope and the indirect ophthalmoscope is that direct ophthalmoscope is used only for examination of the patient, and no therapeutic benefits are there by using direct ophthalmoscope. It is basically for examining the posterior segment, and it's for examination only. That is not the case in case of indirect ophthalmoscope. It is used not only for diagnosis of various retinal disorders, especially retinal detachment, and it can be used as an equipment, operating equipment in case of retinal detachment operation. And you have laser delivery system. For example, if there is a case of diabetic retinopathy, if you want to deliver green laser and do green laser photocoagulation in that particular patient, you can use that as a delivery instrument, laser delivery instrument. So additionally, it can be used as laser delivery instrument for retinal diseases. So apart from indirect ophthalmoscopy, you have a slit lamp delivery system of the laser, and you have what is known as the endoprobe delivery system. Endoprobe delivery system, you have some probes which are extremely small, 18 gauge or 23 gauge, which can penetrate through the pars plana region, and you can directly photocoagulate the area which you want when you are doing vitreoretinal surgery. So these are the advantages of so you must know that indirect ophthalmoscope is used both for examination and for major surgeries on the retina.